name is Mary. I have been a recreation therapist. I actually was doing the math yesterday and it was a lot longer than I thought it was. I'm coming up on my 10-year anniversary. So Noelle, if you're in the room, please don't audit me. I did my master's in TR at SUNY Portland. So if there was anybody from SUNY there, hello, nice to see everybody. And I am currently in operations at Nuvance Health, which is a healthcare network in the Mid-Hudson Valley. There's about 7 hospitals of us. I recently moved into a medical practice, but I was here doing recreation therapy services on a behavioral health unit for most of my tenure here. And that really is what is near and dear to my heart, is looking at people as full people. I think a lot of times when we get a referral on our desk or we have a new intake, we see the person and their chief complaint as the reason why they're coming. And today I'm really hoping that we can look at those full social determinants of health, all of the factors that come into play when we look at the health and well-being of our folks that we work with. So today we're really going to bring that person into a full-fledged context of all of those social, emotional, psychosocial factors that really impact healthcare and how well our folks do when they come to us for TR. Now, because I am in full screen, I may not see things if they're dropped in the chat. So Miguel and Jasmine, if you see things, please just let me know. Or if there are questions, I can't see hands raised. So folks, just feel free to yell it out. Happy to answer whatever questions and have a real interactive experience because I can hear you really well. I just can't see anybody. So feel free to speak up, please. This should be a conversation. I definitely have my sessions. I really prefer that people talk and communicate and we can have a discourse because I am only one perspective. The thing that really makes a full-fledged presentation is when we're all engaged and providing feedback for each other. Okay, let's jump in. So we do have a couple of goals today that we really want to be driving. The first one is identifying at least 3 social determinants of health. So what are they? Let's just start there, right? Let's identify. Then we're going to analyze how one singular health event, one singular health concern can interact with so many of these social determinants of health. People are multivariate and we're going to really dive in and kind of digest and dissect that. And then our third goal today is really to create an actionable step. What's the takeaway here? How can we use this in our practice of therapeutic recreation so that we're making a bigger impact for our patients when we go back to our home facilities? Sound good? Yeah. All right, cool. So before we do any of that, we need to level set a little bit. So I want to take a couple of minutes to just talk about where healthcare is in the United States, really look at some very specific outcomes data so that we're all on the same page of what the current state looks like. Okay, how much do you think the United States spends per person per year on healthcare? What's that dollar amount per person? Any guesses?
Trillion.
What do we think? How much?
Trillion.
$1 trillion per person?
Oh no, I'm talking about the entire. Sorry.
Oh, the entire thing.
The entire thing. Sorry.
Per person, what do we think?
Per person.
5K, 12K, 30K, 100K.
Yeah. 20K.
20K. Okay. All right. It's clear that you all work in healthcare, right? Like we know how expensive services are. So as of 2021, we were spending $12,318 per person. The average across comparable nations is $5,800. We're more than double that. So spending is incredibly high, right? Even the next closest nation, which is Germany, is spending $7,300, $7,400 per person. We are way out in left field. But our outcomes are not reflective of that spend, right? You would say, oh, well, we're spending a lot of money, then our people should be doing really well. We should be super healthy and we should have great healthcare outcomes. But that's not reflective of the data. So you can see here, US life expectancy at birth is 3 years lower than the average of comparable nations. So the US is here. Can you all see my pointer? Yeah, okay, great. Right, so the US is this line here, and you can see starting in the 80s, we're lower, but we're in the middle of the pack. And then as time goes on, comparable nations' life expectancy at birth creeps up and up and up, while the US really stays fairly level and stagnant. Now, you will notice here, starting in 2019, there is a very sharp decline. It's mirrored here in some of the other states that are in comparison. However, it's not nearly as dramatic. So this number is due to the pandemic. It's not only due to COVID, but also all of the other confounding variables that happened when COVID happened, right? We didn't go out and seek healthcare. People weren't being monitored as closely, all of those things. So it's not just COVID, but all of that compounding healthcare, all of those concerns that weren't addressed. And then you can see if we look at that life expectancy in comparison to that spend, it's very evident. So the US is here in this red line, and we are way out, all the way, literally there is an arrow off the grid for how much money the US is spending. Meanwhile, the rest of the nations are sitting right here in this middle marker. And then you can see Japan spending roughly $4,500 per person. They're off the grid in outcomes. Switzerland spending, right, almost, maybe like, 2/3 of what we're spending, and also almost off the grid. So what's going on here? Something's not adding up. Similarly, when we look like across the board at quality metrics, the US is ranked particularly low. So when we look at quality care, we are in the bottom half to last for quality care. Same with access. I don't know if anybody has tried to make a doctor's appointment with a primary care physician recently. Does that experience happen to anyone? My son needs
3 months you can see your primary care.
3 months. Oh, that's not bad, actually. Isn't that terrifying? That's not bad. I don't know where you are in the state, but in the Hudson Valley, there are a couple of companies, organizations that their primary cares are booking out 14 months for new patients. Sick visits are, I had a patient who came to my practice because she couldn't get in with her primary care doc for a sick visit until 2 weeks. She's like, by the time that I get my appointment for the sick visit, I'm going to have resolved, right? Like, this is not a problem. It won't be a problem anymore. It's really, we have a giant access issue. And you can see in comparison, I do want to point this out, in comparison, often the UK and their single payer system, they say, oh, the UK, you wait forever. It's a really long wait time. But you can see here, their access is number one. People are getting in much quicker than the folklore would tell you. And then we also have efficiency metrics. So part of this efficiency is because often we talk about healthcare as like a system in the United States, but because it's not truly one functioning system, but many different systems of payers and patients and practices and government oversight and regulation, all of that adds up and creates massive inefficiencies. So very, very poor system function. And then equity, lowest on equity and lowest on healthy lives. So healthy lives looks at things like diabetes management, mental health concerns, obesity, heart disease, all of those things that are preventable, these healthy lives also ranked last. Right, like we just talked about, so 42.8% of Americans are considered obese. Now, for this metric, obesity is a body mass index of 30, which we all know BMI is not really a great metric, but we can see it is certainly a red flag here that the US is at a 42.8 when we're looking at an average of roughly 25% of folks across comparable nations. Similarly, we also have avoidable deaths. So these come from preventable and treatable illnesses. This metric actually I wanted to share, which I thought was really great. This metric also includes mental health concerns related avoidable deaths, as well as like diabetes, heart disease. And you can see, right, we've always been higher than average since 2000. And like we talked about earlier with life expectancy, there is this metric that rises during the pandemic, reciprocated and reflected in other nations during the same time frame, but at certainly a lower slope. And we seem to be kind of maintaining this line, slightly decreasing, but certainly much higher on average than any of the comparable nations. And of course, this one I find pretty interesting. Adults in the United States are most likely to have multiple chronic conditions. So not just one, you're not just going to have asthma, you're not just going to have heart disease or hypertension, you're gonna have both of those things at the same time. And now some of this is not surprising, right? You may have hypertension, and so you also might have heart disease because these are kind of co-occurring illnesses, and we understand that. But some of this is, you know, two things just compounding against each other. And then I did want to talk a little bit, I know we've kind of talked about it a little bit already, but primary care in the United States, right? We know that our primary care physicians are so incredibly important for preventing disease and for coordinating care to prevent diseases. They are supposed to be, in the system that they were built in, they're supposed to be the quarterback, right? Helping the patient to navigate the system, helping our folks to navigate the system. And only 5 to 8% of all of the healthcare spend in the United States is spent on primary care. In other countries, the average is roughly 14%. So you can see there's quite a disparity here, right? And then our generalists. So think like the intensivists in the hospital, your internists, your baseline cardiologists who do all of the things. There are far more of these folks who do lots of different things for patients in countries like France, where there's roughly 45% of the healthcare population, healthcare providers are generalists. In the US, it's only 12%. Now, part of that is because of our reimbursement system, right? We reimburse physicians much higher for specialties, and we give a lot less clout to the primary care physicians, despite the fact that they really are the first point of contact for the people that we work with. So our outcomes don't look great, right? Like this is really not looking ideal. I'm sorry to start your Tuesday morning off with such beautiful rainbows and sunshine. Really sorry, but I promise it gets better from here. I do want to talk, where does the money go? So in the US, the biggest chunk goes to inpatient and outpatient. So that's things like sick visits, hospital stays, surgical procedures, etc. Then the next biggest chunk is prescription drugs. Then here in the US, the next biggest chunk is administrative, because there's a lot of overhead when there's not a more streamlined system, right? You paying for the overhead for all the insurance, you're paying for all the overhead of all the hospitals, etc. Then you've got your long-term care, and at the very end, before you get to the other category, then you have your preventative medicine. Now, in comparison, this is a way larger chunk to comparable nations, right? We are spending a little bit more on preventative medicine than comparable nations, but it's still not enough. So the question is, okay, this is not good. How do we do better? How do we, what is our role as a recreation therapist in this system so that we can do better for our patients and for the people that we work with, our residents, our individuals, what have you? How do we help them navigate the system so that we can decrease these poor outcomes and start to see some good positive change? So I'd like to think that's through the social determinants of health. Now, what are the social determinants of health? There's a lot of them, right? This is any factor that impacts healthcare for a person. So it could be lots of things. It could be where you grew up. It could be your culture. It could be how much money you make, what education you had. There are so many different factors that play into social determinants of health. And all of these add up and build to create the healthcare environment of the people we work with. So there are lots of ways to look at social determinants. I really like this framework. It's very clear. This one actually comes from Healthy People 2030, which is the US government's look at social determinants of health. And we'll talk a little bit about them later, but I think this is just a really nice, clear way to look at the system. And they give social determinants of health in 5 categories. So the first is education and access, healthcare and quality. Then you've got your neighborhood and your built environment. Where are you? What kind of structures are around you in your neighborhoods? You have your social and community context. Who are your people? Who is around to support you? This is the very personal piece. And then lastly, you've got your economic stability. So we're going to dive into each of these a little bit deeper, really get a good understanding of how they interplay against one another. And then we're going to use these to apply them in a couple of scenarios and then apply them to your practice. How are we doing? Everybody all right?
Doing good.
We're doing good. Okay. I can't see you, so just yell if you have questions or you need to like stretch. Do your thing. All right. So let's first talk about education. This is a two-way street, right? This is much like all of the social determinants of health. There is a relationship between education and health. Education can create opportunities for better health by creating a space where people can earn more income based on their education level. Education is found to have a positive relationship to social and psychological benefits. People who have higher level education are generally considered to have healthier behaviors. And they generally, because of the income that they generate, people with higher levels of education do generally live in healthier neighborhoods. And we'll investigate that a little bit more when we look at the built environment. But on the flip side of this, health also really impacts your education. Think about, I don't know, with the weather changing so dramatically the last couple of days, my sinuses have been awful. I have not wanted to pay attention to anything. And that's a one-day occurrence for me, right? I get back on my allergy routine for the season and I'm okay. But imagine if you had a chronic illness and that was how you felt every day. You would not want to go to school and learn. You might not be able to go to school and learn. And that obviously affects attendance. It's going to impact your concentration. And there's also a correlation between poor health and folks with learning disabilities. So definitely in a really revolving, interconnected relationship here. And of course, as this is happening with health and education interplaying against each other, it's living in an environment with lots of different contextual factors. So not only are you worried about just what's happening in the school, but you also have to contend with the social policies. So what is the Board of Education rolling out? What are some of the political factors that are impacting health and education here? How are they relating to how a person can access their education or access their health in relation to their education? And in a more narrow focus, an individual focus, what is the person in the education system's value network? What norms are around them from their family and their community about education? Is this a person who grew up in an environment where you have to go to college, right? Which is, there are lots of options, right? Like that can't be the only. Or is this a person who never got those positive reinforcements about what education can be, right? Didn't get the opportunity to see what the options and the availability for education really is. So all of this is happening at once. And as we can see, this is only our first social determinant of health. Everything is so intersectional. The next one I want us to look at a little bit here is healthcare access and quality. So in this social determinant of health, we look at access in 5 different ways. The first one is approachability. So this looks at not only the physical space, can you physically approach this? Is this ADA accessible? Is it near your space, near your home, so you can travel to it easily? But also, when you call the phone to make an appointment or you walk through those doors, do you interact with someone who is approachable and makes you feel welcome and wants you to be part of their space? And the next one is acceptability. Do they accept you in the community space where they're doing recreation programming? What kind of signals are you getting in that space that say, I'm accepted here? Do the forms and the paperwork reflect the things about you that make you you and make you feel comfortable and welcome? Availability, of course, can you get in? Can you get an appointment? Accommodation. If you need an accommodation of any kind, whatever that may be, will that setting help you to find that accommodation? Will they work with you? And then affordability. So in many of our settings, we have folks who can't afford, a lot of things. They're struggling. Do we have sliding scales? Do we offer grants or scholarships? Do we just offer things for free or create spaces where there's a buddy program? How do we make our programs affordable so that people from all walks of life can join us? And then as we look at quality, there are 3 main factors when we really assess for quality in our healthcare environment. And I do know that I'm using healthcare a lot. I want you to know that healthcare, of course, includes all of the settings where we provide recreation therapy services. I want you to know that that's really what I'm talking about here. Where are we providing recreation therapy? So in quality, we're looking at provider factors. Are the clinicians, the social workers, the recreation therapists, are all of these different people providing services qualified? Do they have a good bedside manner? Do they build community and rapport with the people that they're working with? Patient factors include a couple of different things, but the big one is cooperation in the treatment, right? When we're working with people, are they looking and following the plan with us and working to develop that plan and really creating a partnership, or is there a barrier there? And why is that barrier there, right? And how do we work around that so that we can provide good quality with that person? And then, of course, environmental factors. What's going on in this person's life and in the facility that they're working in? It's a very different quality experience if you go into the skilled nursing facility and it's really dimly lit and the carpet is bare and there's a video on in the background and everybody's asleep, than if you walk into the same skilled nursing facility and it's really bright and all the windows are open and somebody greets you at the door and everything smells really clean and people are doing an activity, right? That's a totally different quality experience. So our next social determinant is the neighborhood and the built environment. So I don't know if anybody has seen this map before. This is the first time I've seen things that are similar to this, but never on a national scale. And this really kind of shook me. This is from an organization called the Opportunity Atlas, which is a partnership with the Census Bureau and a couple other organizations. And it looks at life expectancy based on county and in some areas based on township. So if you zoom into this map, there are places that on one side of the river, or sometimes literally on one side of the train track, that county has a life expectancy of 58. And on the other side of the river or the train tracks, the life expectancy is in the 70s. And it's a very stark look at how your neighborhood and your built environment can really impact your health. So a neighborhood and built environment also includes what resources are physically in your space. So do you live in a food desert? Is the only access you have to, resources if you have to go across town for 35 minutes? Do you have a library? Is there a post office? Do you have a physician in your space, or do you have to drive? There are some places, particularly in very rural areas, there are some places that you have to drive an hour and a half to 2 hours for women's health services. And so really growing concern in the country is there are a lot, this is a tangent, but there has been a growing trend for women's health services to be shut down in rural communities because they can't support it. There's not enough people having babies. So the OB/GYN labor and deliveries have been closing. And it does mean if women are having babies, they have to drive really far distances, and they're trying to figure out how to keep things open. But again, built environment. Any questions on this, or thoughts or comments? Everybody doing? Yes, okay. So our next one is social community and context. So these are your people. These are folks around you who create an environment around you. So this includes your friends, your family, but it also includes the people in your neighborhood and in your community. There are lots of interesting studies that have come out in the last 10 years or so about social norms in communities where people can use this social capital that they've built to push through agendas. So not unsurprisingly, there are communities where, one group of people makes lots of decisions about healthcare for the entire community. And what does that mean for folks who maybe aren't willing to speak out or aren't able to speak out for whatever reason? And on the flip side, we see these communities who have really strong pull and connection to one another, who are also pushing through social policy in the political arena and in their town boards and their educational systems and their county legislators. So that's a really powerful piece that sometimes we don't think about in the context of someone's health, right? Who are the people around them, and what are those constructs that that community has built for them, right? And what does that mean for someone's health care? And our last one is economic stability. So it's very well known, and this is actually one of the longest studied phenomenon, but right, the wealthier someone is, in general, the healthier that they are. However, there's a caveat to this that I want to share with you because I find this very, very interesting. During booms, big industrial movements over the last 50 to 100 years or so, there are these short bursts, right? Like rapid fire growth. Think Industrial Revolution, Tech Revolution, these kinds of periods of time where everyone's health suffers. The communities directly around these spaces, as well as nationally, health declines during these booms. And on the flip side, during periods of financial hardship or bust periods, people's health actually gets better. And they're trying to tease this apart and really understand this. But what we understand to happen right now is that during these periods of industrialization and really big growth, the environment is worse because we're building and manufacturing and growing at such a rate that our environment is impacted, as are our stress levels. And so this has a negative impact on health. On the flip side, during periods of financial bust, folks are less likely to be out and about. They're less likely to be driving. People are doing more things outside. I mean, the really wild and very clear example of this is during the pandemic, many of us were doing outdoor activities only. We weren't doing as much driving. And you saw national news stories about how good the environment was doing and how we had, I mean, there was a story, I think it was out of Alaska, where whales were coming back into this one bay after decades of being gone because there wasn't any noise pollution in the bay. They could be in there safely. So when we look at people's economic stability in connection to health, we, yes, can look at a direct relationship to their economic status, right? But we also need to look at the time frame of it. So what kind of economic environment are we living in at this time? And how is that going to impact a person's health now? But also looking at that longitudinal data, so because this person in their lifetime has probably seen many booms and busts, and what does that look like for them in peaks and valleys? And how is that also impacting them now? So that was a lot, right? So those are the 5 social determinants of health. And they're big and they're interconnected and they are all encompassing in so many ways. So I like to frame them with this. This comes from Dahlgren et al. From the Institute for Future Studies. And I think it's a really nice way to frame this in your brain when you think about the social determinants of health when somebody comes to you, right? So you start with the person at the middle and all of the things that are truly, truly part of them, right? Age, constitutional factors, sex, genetics to some extent in here, right? All of those things that are really core to who they are as a person. And then you look outside of that one layer, like, you know, like an onion. What are the individual lifestyle factors? What are they doing for work, maybe? What kinds of, you know, places do they live or go to? And then you look outside one more layer, the social and community networks. Who are their friends, their colleagues? Do they have a church that they go to? Do they have clubs or organizations that they're part of? And then as you go out one layer more, they're living in working conditions. So what kind of education, what kind of healthcare services are they involved in? What does their housing look like? Do they have access to food? And then on your last level here, it's really that general socioeconomic, political, environmental factor that really wraps everything up, right? That whole big scope. Now, what I'd really like to do is like marble these because they are so interconnected and so many of them tie into one another. But I do think overall, if you had to pick kind of a framework to look at social determinants of health when you're working with someone in TR practice, I think this is a really great spot to kind of frame your mind when you see somebody. It's also a nice, I like to use this when I do assessment with folks, or if I just kind of do like a social interview and want to do something a little bit more informal, I'll have this in front of me and just kind of make sure that I ask about each of these layers for someone so I really have a good understanding of who they are inside of this context. Anybody have any questions about this framework or anything that I've talked about so far? How are we doing? Good? Okay. And you know, I've been doing a lot of talking, so if anybody needs to like get up, move around, let me know. Okay. We're good? All right. Let's get cruising. Okay, so we learned about the things. Now let's incorporate them into our practice. education alone, it cannot be changed. We need to apply what we've learned to make an impact. So I like to look at this in two ways. The first is critical thinking, right? So when I work with somebody and I work with a group of folks, how are we going to work with this person to create individual development? What are the programmatic goals? And I also want to really look at the power dynamic. We as recreation therapists do hold a position of power when working with people, right? We come from a place of authority in recreation therapy, and we need to have a cognizance of this, right? We impact, and that power dynamic impacts that relationship. We need to understand where our people are coming from so that we can adjust and function in that power dynamic in a way that's therapeutically appropriate. And then I also want us to think about critical consciousness, right? Not just critical thinking, but also critical consciousness, really steeping that inside of ourselves. We need to practice this contextualized way of social determinants of health, looking at all of our people as not just the person standing directly in front of me right now, but a person who is full of all of these pieces, these puzzle pieces that bring them together. We also need to look at societal issues. We need to have an awareness of our organization in the context of our community and in our nation. We need to know what's happening around us so that we can function within that, right? And so that we can adjust within that. And as recreation therapists, we also need to advocate for change. It's not enough to just know what these issues are. We also need to be working towards fixing and changing and bettering. And that sounds really big, right? But it doesn't have to be. I tell a story. I had a colleague. She has only been in the organization for like 6 months. She's a little shy, doesn't really like to speak up that much. But she sent me an email and was like, hey, when we do an intake on somebody and we're bringing them in for services, I noticed that you can't change the gender for a person in the registration. And we have a patient who's transitioning and I want their gender to reflect their identity. And I can't change it. What do I do? So it's like, well, you need to send an email to this person. Nobody had said anything. This had probably been going on for a couple of years that we had gone to a new registration system. She was the first person to say anything. But because she spoke up, it went all the way up to my vice president. And so now they're reworking that registration system so that our patients, when they come to us, can express their identity the way that they identify and they're not judged. And, when a person comes in to your service, right, the last thing you want is to start with that wrong foot, right? You want them to come in and walk in and feel welcome and not have that happen. And so with one little email, she was able to change a great big thing. So advocacy doesn't have to be a huge ordeal. There we go. Okay, so there are 5 A's to address social determinants of health that I really like. The first is awareness. So this comes down to assessment. And I do want to point out that because of value-based medicine and the growth of value-based medicine and care that's coming forward, insurance companies are often tying reimbursement to these assessments. So in your agencies, wherever you may be, you might want to look at your assessments and what those look like and whether or not you can get credit for those. And then the next one is adjustment of the organization, of the recreation therapist, working to adapt that environment for the person that you're working with. The next is assistance. So this is really care planning, motivational interviewing, learning about this person, and then connecting them and assisting them to get to the resources that they need. In recreation therapy, this often looks like, when we're out doing community events or helping people identify resources in their environment and working with folks to connect them to those spaces in a way that creates independence and sometimes scaffolding, right? And then the next one is alignment. It's really great when we are able to look at all of the different entities that exist in our community that are helpful for folks and bring them together to create these connections so that we can do a warm handoff. There's nothing better than when I get to call you know, we have somebody who comes into the rehab and is staying with us for a couple of days. And I get to call the recreation therapist who's going to be doing the community side with them and say, hey, I've got Mrs. Smith here. She's going to be joining you in a couple of days. I'm so excited to tell you that her goals are X, Y, Z, and she really loves, you know, A, B, C. And it's a warm handoff so that when Mrs. Jones comes to the community facility, they already know her. They can already start off with a warm embrace. And then, as we talked about before, that advocacy piece. So there are a couple of national efforts. I'm not going to go into these too far, but these are available for you to kind of take a look at. These are things that are happening on a national level for social determinants of health. Many of them, if you have any interest, are also tied to grant funding. The Robert Wood Johnson Foundation is a great place to start for that. If any of you are like, yes, I want to take on the world, let's do it. Please let me know, I want to help. But also, if you need funding, Robert Wood Johnson is really a great place to start looking. Okay, so we're going to do an activity. Jasmine, Miguel, how many do we have in the room?
They're gone.
Oh, they're gone. Okay.
She gave the moderator back at primary and taking over. 15.
Might have to speak up a little louder.
It's
It's 15.
Thank you. Okay, I thought that's what I heard, but I wasn't sure. It's 15. Thank you. All right. We are going to break up in a moment. We'll break up into 3 groups of 5. I want to share with you when we do this activity, I'll put the worksheet on the screen for you all to see, so you can work off of that. But what I would like us to do is dive into these social determinants of health just a little bit. So this is, can you all see the worksheet?
No.
Oh, no.
Oh,
Hold on, sometimes. Can you see it? You can see it now, right? Okay, so this is the social determinants of health in TR practice worksheet. What I want you to do, and I have 3 examples, but you can certainly pick as you sit and talk in your groups, you can pick a health concern that is really applicable to your TR practice as well. What you're going to do is you're going to put that health concern at the top, and then I want you to use this framework to really dissect that health concern and pull it apart so that we can look at it from a social determinants of health framework. So let's say that you're looking at heart disease, right? So for proximal issues, maybe this person has heart disease because they're eating unhealthy foods, they're not exercising. But then as you dig a little deeper and you look at more of the intermediate areas, you see that they are in a low resource neighborhood. They're living in a food desert. They don't have any green space or any parks. Like, oh, okay, well, they can't really exercise and they can't really get groceries. And then as you really look at the bigger societal concerns, you're looking at the fact that this person maybe has low income, and it's really creating this risk because they can't live in an environment where they have access to these things, right? It's also, it's increasing day-to-day stress, which is not helping their heart disease. And then as you shift over to the next column, I want you to think about social safety net policies, right? And all of these prevention methods that we could be looking at either upstream or downstream from the person to really mitigate these effects of heart disease. And then for you all, the last column is who do you work with here, right? So we might not be in our practice able to really work on some of these bigger global issues directly impacting this person, but you might have partners in your community that you might be able to reach out to and connect with and create that synergy, right? to make those impacts and make that change. So if folks want to divide into 3 groups of 5, I have the ones that I kind of picked were substance use disorder. If one group wants to do substance use disorder, another group, I had a recent left lower extremity amputation. And then the last one was a recent stroke. So I'm going to give everybody about 10, 12 minutes to work on this in your groups, and then we'll get back together and we'll talk about it.
Can you repeat those?
Yes, I'm sorry. Yes. So one group is a recent stroke. Recent stroke. One group was a recent left lower extremity amputation. And the last one is someone in your practice who has a substance use disorder. You can create the context around these people however you would like. You can decide their age, you can decide their occupation, their neighborhood, really flesh these folks out, and then take a deep dive into the proximal, intermediate, and distal areas of concern. And I obviously will be right here if you have any questions.
I'll move over.
Mary, can you slide the screen up so that people can see the figure, the diagram thing? That, yeah. That's internet, by the way. So you did that.
Hi, Annette.
Okay, yeah.
So, all right.
Possibly do the process. Right, and then the part of this would be the.
So we're gonna make about that.
Well, the. So what do we do for? Yes.
No, hard to hear. No, bad, no, see it wrong.
Yes. Like setting up conditions.
They kind of scream through and
So that's why I thought basically for the meeting office,
no, things improvement and family that supports programs.
yeah, yeah, that's where I'm laughing, I'm like,
I don't know where. Yeah, before.
Yeah.
The last I remember was driving to Sherry on that one. Yeah. I live all the way out in that's what I'm thinking of that are. The rash them, I went to my string of.
Yes, I was gonna ask, but I'm kind of not funny, I think. I sat with one right now. And then-
Oh, the weather's okay. I didn't shine. I got like it's like I'm not Friday. So I didn't hit any of those. Right. Okay. Yeah.
Yes, yes.
Yeah, because like the practical, I got to be like, you know, probably really. That came up Friday too.
Like we started doing all that, and then we had, pretty good for like.
Yeah, like, I did every step.
Hopefully you take her off there. Hopefully we're leaving it like.
In between the right.
We've been actual physical spaces.
Yeah.
That's great.
Yeah.
Yeah, I understand my rates. So enjoy the regional. And it's.
Take a couple more minutes to really go deep. And then you're gonna wanna pick one person who will be your spokesperson. So we can kind of talk about each of these people.
Okay.
And every single person speaking, and help and supporting that person through that, and let's take a break. That should be equal. No, to reach.
Right, like, we didn't really started to get more of that, we have once that after that. And that was not part of like, having a lot of like, I can barely function, right, so. Yeah.
And then like fun stuff around, I mean, without being. Yeah. That's a way to do that. You know, like when you're sick and someone comes and visits you, you can go break, so, you know, just.
It's very fun, that we must have learning lots of people. It's that first meeting of how we do all this.
So. Yeah, whatever.
Okay, everybody, how are we doing?
I think we're done.
I think we're done. Okay, I was trying to listen for the quiet, but I also know you get too many people from Nicer together and, you know, it's hard to find that lull. So Jasmine and Miguel, you might just kind of have to help me out. Is there one group that wants to go first?
Let's go first, stroke.
All right, Team Stroke, can you introduce the person that you developed and then kind of talk to us starting from the very proximal, very close parts of this person and kind of walk us through all of the factors as you work out.
All right, so our first child had a stroke, a male in his 60s, lifetime smoker. Also diagnosed with high blood pressure and diabetes, and has a bad diet. For the intermediate, he works in construction and has no family support. For distal, low income neighborhood and low education. And then for the TR prevention, as far as the proximal, thought maybe starting with an exercise program or a nutritional program or and the partners involved with that would be doctors and nutrition.
Great, absolutely.
Immediate, with the construction and no family support, we said create a rapport, social groups, and maybe starting in a local community program. For the distal ones, the low income neighborhood and the low education, we just said leisure education for his neighborhood. And as far as people to work with, partners to work with, doctors, nutrition, social work, and the community center.
Awesome. Yeah, absolutely. I think you hit it on right on the head. Are there challenges that what kind of challenges do you think you're going to come across if you work with this person, given all of their social determinant of health concerns?
Probably resistance just from a life of living a certain way. and maybe not wanting to change.
Yeah, absolutely. And what kind of goals and ambitions do you think this person might have that you could leverage to kind of work with them?
I don't know.
It's really hard to think about that, right? Because this person is so ill and is couched in all of these different factors that have really built up around them to create this space for them, right? So maybe that's one of the barriers, but also part of our job is right is to kind of chip away at that a little bit and really get to what they want. Awesome. Thank you so much for presenting for your group. I think that was perfect. That's exactly the kind of thing that we're looking at. What community partners can we access? What are our roles in working in this context? Awesome. Team recent amputation. Do you guys want to go next?
Can you just scroll to the other thingy, because I think we did the first part a little wrong, but I think I can manage. Can you scroll to the, yeah, okay. So, our individual is 45-year-old female, she's type 1 diabetics, which caused her lower limb amputation. She lives with her family in a lower income trailer park. So for proximal, we kind of answered this first section maybe a little incorrectly, but we're talking about mobility and circulation as one of the like most immediate issues. So I would guess that would be more of just like an individual health factor.
Yep, absolutely. Yeah, that's still very proximal, right? That's still very near to their personhood. Yep.
And then intermediate, I would say would be more of like the emotional conditions that the person has to live with, but I don't know. Fit that in there somewhere else. I can't really see it. Just hit it wrong.
Yeah, we were kind of looking at like, their impacts on their health, like.
Okay,
From,
yeah, so I would say like the healthcare services would be the intermediate maybe.
Okay, yep, certainly. So what kinds of things are available to them in their community, right? Does this person,
That, which led to the amputation and everything, and then distal would be more of, the like. I guess the social areas, what she's allowed to access, with accessibility. Maybe.
yeah, so, right, there is an acceptability factor here. So, and in accessibility, right? What can this person get to? Do they have, where is their food source, right? Where they're living. Their housing is a factor, right? Because maybe mobility is an issue. Maybe there are stairs up to their trailer where they're living. And so they're having a hard time now that they've had this amputation to get in and out of the house to go to services.
And then
Maybe,
having to get a ramp and all of the changes that would involve with the finance portion of changing your life to have an amputation. So the TR specific preventable method, we talked about like the physical therapy portion, but TR specific is more about giving hope and like reasons for continuing to want to be with your family and your kids. Intermediate, we talked about continually through education and finding things that the person would like to do outside the home. And then distal, we talked about community reintegration and other places in the community that they are able to recreate with their family and friends. And then the partners to involve, we talked about Proxol being like a community hub or like strengthening their spirit type of connection. So it's, reintegrating your normal life and the needs involved with, getting groceries and cooking, and is all of that even affected by a lower limb amputation? Intermediate, we talked about community accessibility, and then distal, we talked about reintegrating into family and friends' homes and not just having people meet you in the community, but what do you need to integrate into like your family holidays at your aunt's house that you used to do, and not just having everybody change their whole life for you again, and feeling like you're just part of the family like you used to be. So just starting at like the personal level on like what they need, and then going into what the family needs to help them all the way around.
Yeah, absolutely. I think that's a really great take on this framework. I think that's beautiful. I would encourage looking at those really big factors of like, okay, what's happening in their community that, they're not able to get services for their type 1 diabetes that led to an amputation, and really looking at those social constructs as well. But this is it, absolutely, this is beautiful. And I really liked how you looked at that community piece really in depth. I think that's going to be very important for this person as they move forward. So thank you so much. All right, last group, SUD.
Can you hear me okay, Mary?
Yes, beautifully, thank you.
So we had the substance abuse. We thought it was a 45-year-old male who had had gastric bypass surgery that developed a secondary substance abuse problem. He's single, lives in an apartment in a city. So for proximal health concerns, we identified that the surgery required like opiates for pain management and which led to the substance abuse and addiction. Intermediate, I can't read enough writing. So well, like his access to services, I guess, location of like his post care treatment services, like maybe he lives in the city, they're on the outskirts, or he has difficulty with transportation, and you can get to know something like that. And then for distal, he's a lack of support at home or resources.
Yeah, absolutely. So thinking about, right, all of those different factors that are inhibiting him, right? So not having transportation means he can't go to doctor's appointments, means he, is having that social isolation component, right? This person can't get out, they can't see friends. That definitely does not help when you have substance use, right? And then looking at, again, those bigger societal concerns, right? So the person was prescribed opiates after their surgery, ended up having a substance use disorder as a consequence of being overprescribed opioids, possibly, right? And where does that fit in our current social political climate, right? We recently, there were just lawsuits that were just settled about opioid overuse with the major pharma companies. How does that play in? Could this person maybe now be a beneficiary of that in the class action lawsuit? Can we create some kind of resource for him from that? And really looking at all of those overarching factors. When we look at this onion, we really want to go all the way out to that national, global level for these folks, because this political climate, social, economical, cultural climate, these things really trickle down and seep into those individual lifestyle factors as well. Does that make sense?
Yeah.
Right.
Yeah.
Okay. Yeah, we really want to look at that big picture and understand. Fantastic. So what I want everybody to do now, you can stay in your groups of 5, and I want you to think about your TR practice, wherever that may be, whether you are in a community setting, a skilled nursing facility, a psychiatric hospital, wherever. I think I picked some of the big ones in the room. And I want you to think about 3 things that you can do, whether that's improving your assessment, if that's adding maybe a new program, whether that is building a relationship with somewhere in the community. I want you to think about 3 things that you can do when you go back to your home facility to implement, to have a greater understanding of a person's social determinants of health. It doesn't have to be big. Like we said, advocacy can be a drop in, one drop in the bucket creates many ripple effects. So think about 3 things and take about 5 minutes to do that, and then we're going to get back together. And obviously feel free to talk in your groups a little bit.
Think about our own side. Yeah, that's. What would you transfer this stuff for a lot? Normal. Senior stuff. Programs are, we're missing some bad. Based on.
Yeah, you know, like already, like, like in not most. That I work with, I'm for being retired and for being. I was wondering.
Okay, folks,
Really.
let's bring it back a little bit and we'll wrap up for today. Who has a really cool, innovative thing that they are going to bring back to address social determinants of health and examine social determinants of health at their facility?
Okay, are you guys ready? You ready? We'll get it. I guess you want us to go first? Yeah. So for us, we talked about reaching out to the families more to get a better history of what their life was like prior to admission. and what those social issues might have been, prior. We talked about possibly reaching out to patients after discharge to see how they are adjusting back to life after discharge. And then reaching out to like a local community center to build a rapport with them to send patients to.
Awesome. All of that sounds fantastic. I know, I think at least in places where I've worked, it's a really hard thing to follow patients after they've discharged, because somebody comes right, somebody discharges and you get an admission right after and they've discharged, right? But following them, whether it's even just a phone call 7 days later, hey, how you doing, right? Or making sure that they followed up with referrals, that's a huge impact that can really have a great ripple effect in social determinants of health, because now they've got somebody looking out for them. That's awesome. Love it. Somebody else want to share some really interesting, innovative ideas? What are you bringing back?
Well, we were thinking of. Like, in our assessments, we really don't look at that part of the social determinant stuff and all that. And maybe digging a little deeper into that and putting those things into our assessment to later be able to help them better. I think we've had those conversations and we've learned it, but it's not something we actually like assess. You know what I mean?
Yeah, I totally do.
And
It's
my
not-
sources would be, which are far and few between.
Yeah, I think those assessments are really key, because we talk to our patients. We are the chattiest of the therapies, right? We love to talk. I have found over the years, not to make a like hasty generalization, but over the years, I find patients want to tell me things when they will not tell any of the other therapies, right?
Agreed.
They love to disclose. So then they tell us, and yeah, we might have an offhand conversation. You know, the social worker walks past my door and I'm like, hey, just so you know, so-and-so told me XYZ, probably want to address that before discharge, but then it's not in the assessment, right? And so we don't document it. So the next time they get admitted, we have to learn that all over again, right? So I think that's a great thing. Let's look at assessments. I do want to let you know that in the resources, there are a couple spaces where assessments are happening. So if you want like a form for how to kind of add things to your assessment, it's in that resource page. Last group, what do you want to bring back?
I'll go closer to the mic. We kind of had a, can you hear me okay, Mary?
Beautifully, thank you.
We kind of did a general discussion. I thought, you know what, I'm working with seniors outpatient and everyone works with different folks. We kind of thought like, talk to the folks, what do you need? You know, based on all this stuff in terms of your health and your outlook and stuff like that. And every setting was a little bit different. So I think more assessment on what the folks need. And like you said, you know, talking to people and access to healthcare, affordability. And then also in terms of mental health stuff all along the way and leisure education to just boost people's moods and lower the stress and, you know, that kind of stuff. General good stuff.
I love general good stuff. I agree with you. I would really love for all kids who are in school to have leisure education and mental health classes. I don't like just, you know, like big picture advocacy. That is one of my dreams, is that every child starting in kindergarten has a well-being class. I know that they do like social emotional learning now is really big in schools, but that needs to get carried forward and look at mental health and look at leisure education right from the get-go. Brilliant, y'all. I love general good stuff. Okay, folks. So in the last, you know, hour and 20 minutes, we have really done a very, you know, like cursory dive. It's been a very generalist, wide range. There's lots of opportunity to take deep dives into this if your particular area, specialty of practice focuses on one of these things or others. I'm always around to provide resources. Like I said, this is an area that's really near and dear to my heart because I actually worked in geri psych for a long time And what would happen is patients would come to us with an acute mental health concern, and we would help stabilize, and then they would discharge, and then they'd come right back to us because we weren't addressing the root cause, right? We weren't looking at those social determinants of health. And not until we started really taking that wider scope of like, hey, what's going on here, did things start to really improve for people.
Because we're in TR, we're in human services, but so many people aren't, and they don't think like we think. They really don't in terms of proactive health, physical health, mental health. You know, yeah, so we got it from the ground up and lifelong, because we're like really good.
Yeah.
We're our friends,
We are the
therapists,
people.
we're planning. People are like, that's a coping, what's a coping skill? I mean, they go through life blindly. Don't you guys like diagnose all your friends? But some, and they're smart people, they just don't know the stuff we know, right?
Right. And we, because of our education in recreation therapy and our practice of recreation therapy, we think about this stuff all the time. And not to be on a soapbox, y'all, but we are powerful. We have voice. Use it, because a lot of us know all of this, right? Like maybe I put some new words and new vocabulary in your mouth today, but we really do live this a lot throughout the day. But we got to spread it, right? We got to share this. I will now get off my soapbox. Other thoughts, feelings, opinions, questions about today? Other resources that you might want? Thanks, everybody. Hey, go get
Great,
breakfast.
this is great, Mary. I know you can't see us. We love you.
Oh,
Thank
good.
you, thank you.
Thank you all
I
so much
miss
for
seeing
being here.
you.
I know. Hopefully I'll be back next year. I'm really sad that I didn't get to be here this year. Okay. Thanks, everybody. Be well. I'll send the slides to Jess and the conference committee. So if anybody wants them, you can have them.
Okay, thank you.
Thanks, everybody. Be well.